Let me tell you about a patient. I'll call him Arthur. He was 72, retired structural engineer, walked 3 miles every morning, could still do 5-digit multiplication in his head faster than his grandchildren could punch it into a phone. His wife told me he had the memory of a steel trap and the discipline of an old clockmaker. Then his primary care doctor prescribed something for the burning nerve pain creeping through both his feet. A few weeks later, something else to help him sleep because the nerve pain was now keeping him up at 2 a.m. A month after that, something else for the anxiety that had started surfacing for no reason he could name. Within 10 months, Arthur's wife sat across from me in my office with her hands folded tight. He'd gotten lost driving home from his own Tuesday breakfast club. He forgot which grandson he was talking to mid-sentence. He asked the same question 4 times over coffee. His neurologist had already scheduled a spinal tap and a PET scan. The family was bracing for an Alzheimer's verdict. But here's the part that still makes my jaw tighten. Arthur didn't have Alzheimer's. He had a medicine interaction that no single prescriber had bothered to map. When we sat down with his full medication list, went line by line, and worked with his physician to systematically swap each drug for a safer option for an aging brain, Arthur came back. 6 months later, he was back at Tuesday Breakfast Club, finding his own way home with no GPS, sharp again, almost all the way sharp. This is not a happy ending because we got lucky. It's a happy ending because somebody finally paid attention. And today I am going to walk you through 9 medications that are quietly, invisibly, and legally being prescribed to millions of seniors right now, ranked from the most overlooked all the way to a hidden pattern no doctor is doing the math on. I'm Dr. Sandra, and this could be one of the most important 20 minutes you spend this year. One thing before we start, stay with me all the way to number 1, because number 1 isn't a single medication at all. It's a pattern happening right now in medicine cabinets across this country that almost no one is willing to discuss. Let's get into it. Now, I want to be extremely clear about one thing before we walk through this list. I am not telling you to stop any medication on your own. Please don't do that without your physician's direct guidance. What I am telling you is that you have a right to ask questions, to understand what's going into your body, and to protect the organ that makes you, you. Silence is not safety. Silence is the most dangerous prescription of all. Also, drop a comment right now. Tell me, are you over 60? What are you currently taking? I read every comment on this channel. I want to understand what you're navigating, and your experience may be the thing that helps someone else watching right now. All right, number 9, cyclobenzaprine, brand name Flexeril. Let me ask you something direct. How many of you have been prescribed cyclobenzaprine for back spasms, for a stiff neck, for that one shoulder that never quite healed after the fall in the garage? A lot of you, I'm guessing. Because cyclobenzaprine is one of the most widely prescribed muscle relaxants in North America. It's handed out the way trainers hand out water bottles, quick, easy, no big conversation. Here's the part of the conversation that almost never happens. Cyclobenzaprine sits high on what we call the anticholinergic cognitive burden scale. We are going to talk about this term a lot in this video, so settle it in your mind now. The scale scores how much a drug blocks a chemical messenger in your brain called acetylcholine. Acetylcholine is the messenger responsible for memory formation, focus, attention, learning. Block it heavily in a 60-year-old brain and you are directly cutting the phone line between your neurons. A 2009 review at UCSF's Memory and Aging Center flagged cyclobenzaprine specifically as a drug that can mimic or worsen dementia-like symptoms in older adults. Long-term muscle relaxant use has been associated with measurable cognitive decline, increased fall risk, sedation, and what physicians sometimes call pseudodementia, cognitive impairment that looks like Alzheimer's but is actually drug-induced. The cruelest part is that the prescription often felt generous at the moment. The doctor saw your pain and tried to help. Nobody on the other end of that prescription pad was thinking about your memory 6 months down the road. If you are on cyclobenzaprine and you've noticed brain fog, word-finding trouble, or a fuzziness that wasn't there before, please bring this specific concern to your prescriber. There are alternatives. Methocarbamol is one. Targeted physical therapy and gentle stretching regimens are another, and sometimes the answer is simply a slow taper, not a permanent lifestyle of the pill. Medication number 8, meclizine, sold over the counter as Dramamine, Bonine, Antivert. Raise your hand if you have ever bought this for a cruise, a road trip, or the vertigo that hits when you roll over in bed the wrong way. Now imagine that you are 68 years old and you've been taking it almost every day for the last 2 years because your inner ear never quite recovered from that vestibular infection you caught in 2023. Here is what meclizine is doing inside your brain. Meclizine is a first-generation antihistamine. Its mechanism of action for stopping nausea is identical to the mechanism that gives the older allergy drugs their side effects. It crosses into your central nervous system and suppresses acetylcholine activity throughout the cortex. Your inner ear feels better. Your hippocampus pays the bill. A 2024 study published in the Journal of Allergy and Clinical Immunology in Practice specifically examined H1 antihistamines and the risk of dementia in patients with chronic allergic rhinitis. The cumulative exposure picture is the same one we've seen for decades. The more you take, the more your brain records the damage. What to do instead? If your vertigo is positional, the Epley maneuver, a guided head positioning technique a vestibular therapist can teach you in a single visit, resolves most benign positional vertigo permanently. For motion sensitivity on flights and cruises, scopolamine patches at the lowest effective dose and the shortest possible duration are usually a better choice than daily oral meclizine. And if you are on meclizine every day for what your doctor called chronic vestibular dysfunction, please ask whether you've ever been evaluated for the underlying cause versus just being handed a daily pill for the symptom. Stay with me. Type the number 8 in the comments. Just 8. It tells me you're still here and that this is landing the way it needs to. Medication number 7, hydroxyzine. Brand names Atarax, Vistaril. Hydroxyzine has a kind of Jekyll and Hyde reputation in medicine. On one hand, it's used in hospitals for nausea, itching, anxiety, and as a sedative before procedures. On the other hand, it is now being prescribed long-term for everything from generalized anxiety to insomnia to chronic itching in older adults. That last category is exploding right now because dermatologists across the country are searching for safer alternatives to long-term steroid creams, and they are landing on hydroxyzine. Here is what a 2021 Swedish prescription review published in the journal Drugs, real-world outcomes found when it looked at more than 1 million older adults on chronic anticholinergic therapy. Hydroxyzine, alongside promethazine, accounted for nearly 59% of all anticholinergic drug use in the elderly population studied. Nearly 6 out of every 10 older patients on these sedating antihistamines. The medication comes from a doctor. The prescription gets refilled. The conversation about what it is doing to memory almost never happens. A 2016 review in Revista de Psiquiatría y Salud Mental examined long-term anticholinergic use and cognitive decline and found that hydroxyzine in particular, used continuously, contributed to measurable worsening in working memory and processing speed. The mechanism is the same one we keep seeing. Block acetylcholine long enough and the brain begins to lose the physical architecture needed for clean recall. What to do instead? For anxiety in older adults, buspirone offers relief without the cognitive weight. For insomnia, structured cognitive behavioral therapy for insomnia, CBTI, has stronger long-term outcomes than any antihistamine. For chronic itching, non-sedating options like narrowband UVB light therapy and topical emollients can dramatically reduce the need for systemic sedation altogether. Medication number 6, promethazine, brand name Phenergan. This one truly annoys me, not because the drug is uniquely evil, but because of how casually it gets handed out. Promethazine shows up as a nausea pill in emergency rooms after stomach flu. It shows up in hospice bags to help relatives calm an agitated loved one. It shows up in the average home first aid drawer because someone's grandmother swore by it for sleep back in the 1980s. But here is what you didn't know. The 2021 Swedish review I just mentioned placed promethazine and hydroxyzine in the same top tier of anticholinergic burden in the elderly. Promethazine sits at the absolute peak of that scale. Long-term use has been linked to measurable hippocampal volume loss in imaging studies. Your memory filing center, the hippocampus. We are not talking about temporary fog, we are talking about structural shrinkage. What is worse, promethazine is often prescribed or administered during acute hospitalizations and then accidentally stays on the medication list after discharge. The patient goes home on a medication they never needed for an ongoing condition. 6 months later, their family starts to wonder why mom seems different. If a clinician is recommending promethazine for a brief defined window during an acute illness, that is one conversation. If it's on your active medication list and you have been on it for longer than 2 weeks, please bring it up. There are far safer antiemetics on the formulary. Ondansetron is one of them. It does not carry the same anticholinergic weight at standard doses and works more reliably. Medication number 5, scopolamine patches, often sold as transderm scop. Picture this. You are 71 years old. You and your wife are about to board a 14-day Mediterranean cruise. You tell your doctor that the last cruise made you seasick for the first 3 days. He writes you a scopolamine patch, and you put it behind your ear before dinner the night before sailing. The patch delivers a steady stream of medication for 72 hours. For one trip, that is reasonable. Here's what concerns me. I am now seeing more older patients wearing scopolamine patches for daily symptoms. A little dizziness, a vague wobbliness, persistent nausea they cannot fully explain. The convenience of a once every 3 days patch turns a short-term travel tool into a de facto long-term therapy without anyone in the room making that decision on purpose. A 2009 case series published by SEO and colleagues in the journal Clinical Therapeutics documented multiple cases where elderly patients developed acute mental confusion and frank delirium within hours of applying a scopolamine patch. A 2014 review by Dr. George Roman of the Alzheimer's Disease Research Center described scopolamine as producing what he termed a cholinergic stress test in vulnerable elderly brains. The patch itself wasn't designed for daily wear. It was designed for predictable, brief, motion-bound circumstances. If you have a scopolamine patch on your body right now and you have not boarded a vessel in the past week, please take it off, call your physician, and ask what symptom you are actually treating. Long-term scopolamine use in an aging brain is a setup for falls, delirium, and cognitive injury that didn't need to happen. Medication number 4, zolpidem, brand name Ambien. I want to pause on this one because Z-drugs, and zolpidem in particular, occupy a strange place in the conversation about senior sleep. On the one hand, they are marketed as safer than benzodiazepines. On the other, they are being prescribed to millions of older adults for insomnia that almost always has a structural, addressable cause: pain, sleep apnea, anxiety, depression, late-night screen exposure, alcohol use. A 2017 nationwide Taiwanese study published in the journal Medicine found that cumulative high-dose zolpidem use was significantly associated with an increased risk of Alzheimer's disease among older adults. A 2019 study in the journal Frontiers in Pharmacology specifically looked at benzodiazepines combined with Z-hypnotics. That's the technical family zolpidem sits-in-Siamine, and found that older adults using combinations of these sedatives faced nearly 5 times the rate of dementia compared with non-users. 5 times. And here's the part that breaks my heart as a physician. Often the patient asks for zolpidem because they want to sleep. Often the doctor prescribes it because the patient asked for it. Sleep is sacred. Sleeplessness is genuinely miserable. But most chronic insomnia in adults over 60 responds best to cognitive behavioral therapy for insomnia, CBTI again, which has been shown in dozens of trials to outperform pharmacological sleep aids for long-term outcomes without any cognitive risk profile at all. If your physician suggests zolpidem, please ask, is this the shortest effective trial? Are we addressing the underlying sleep architecture issue? And what is our exit plan at 14 days? If the answer to any of those questions is unclear, that is a conversation worth having before you start. Medication number 3, beta blockers. This one is going to surprise some of you because beta blockers are not on most people's worry list. Atenolol, metoprolol, carvedilol, bisoprolol. Millions of older adults are on them for blood pressure, for atrial fibrillation, for heart failure, for migraine prevention. They have saved an enormous number of lives. But a 2020 nationwide population study from Iceland, published in the journal Alzheimer's and Dementia, found something that warrants honest discussion. Beta blocker use in the general elderly population was associated with a 2-fold increased risk of subsequent vascular dementia. 2-fold. Not because the medication is unsafe in its intended use, but because the way it interacts with cerebral blood vessel tone over years, particularly in vulnerable patients, may accelerate the kind of small vessel damage that produces vascular cognitive impairment. Let me be very careful here. I am not telling anyone to stop a beta blocker that their cardiologist prescribed for a heart condition. Beta blockers have real life-saving benefit in many contexts. What I'm telling you is this. If you have been on a beta blocker for many years, particularly for borderline blood pressure control or for migraine prevention, rather than for a cardiac indication, please ask your doctor whether the original indication still applies, whether the dose is still right for your current age and kidney function, whether an alternative like an ARB or a calcium channel blocker might deliver similar cardiovascular benefit with a different neurological profile. What we are really doing here is asking the same question every doctor should ask every few years about every medication on your list. Is this still doing more good than harm for the body I currently have? Medication number 2, gabapentin, brand name Neurontin. This is the one I want you to pay closest attention to right now because it is being prescribed at a pace that outruns the medical community's full understanding of what it does to the aging brain long term. Gabapentin was originally developed as an anticonvulsant. It found its real commercial home as a nerve pain medication. Burning feet, diabetic neuropathy, post-herpetic neuralgia, back pain that radiates down the leg, fibromyalgia, off-label anxiety disorders. The list keeps growing. A 2025 study published in BMJ's Regional Anesthesia and Pain Medicine tracked thousands of patients prescribed gabapentin for chronic low back pain. Adults between 35 and 49 who received 6 or more gabapentin prescriptions had more than twice the risk of developing dementia compared with non-users. The risk of mild cognitive impairment more than tripled in that same age group. In older adults, the picture was less dramatic, but the direction of risk was consistent. Senior patients on multiple gabapentin prescriptions showed a 29% increased risk of dementia and an 85% increased risk of mild cognitive impairment. I want to be careful with the framing. Chronic pain is real. Nerve pain is genuinely miserable and deserves treatment. I am not making light of any of that. But gabapentin is being handed out like it is a safe, all-purpose pill. And the cumulative cognitive picture is now large enough that we have to take it seriously. If you are on gabapentin for a clearly defined nerve pain syndrome and it is working and your cognition is intact, that is a legitimate clinical decision to stay on it. If you are on gabapentin for vague, chronic, multi-site pain that never had a clean nerve diagnosis, please ask your prescriber whether you have ever tried the safer alternatives first. Duloxetine works on multiple pain pathways and carries a much lighter cognitive footprint. Topical lidocaine patches target localized nerve pain without systemic exposure. Structured physical therapy and graded exercise can sometimes resolve the original pain generator entirely. If you have made it this far with me, hit the like button. It is a small gesture, but it puts this video in front of the people who most need it. Medication number 1, the polypharmacy anticholinergic stack. All right, we have arrived at the entry I told you at the beginning of this video would not be a single medication, and I want to explain why this matters more than any other item on the list. Every single drug we just talked about, taken alone, may produce only mild and easily dismissed cognitive changes in some people, easy to pass off as age, easy to miss at a routine primary care visit. But here is the part your pharmacist probably never told you. Seniors do not take one medication. The average American over 65 fills 4 or more prescriptions at any given time. Many take 7, 9, 12, sometimes more. A cocktail of prescription drugs, over-the-counter products, herbal supplements, and PRN pain relievers, often prescribed or recommended by 3, 4, or 5 different clinicians who may not have full visibility into one another's choices. When several of those drugs carry anticholinergic properties, they do not silently add together. A 2024 review of Swedish national prescribing data found that older adults carrying what physicians classify as a severe anticholinergic burden faced a 227% increased risk of developing cognitive impairment compared with low-burden patients. A 2015 study in JAMA Internal Medicine, still one of the most cited pieces in this entire field, found that cumulative use of strong anticholinergics for the equivalent of 3 years or more was associated with a 54% higher dementia risk. Let me walk you through what this looks like in real life. Picture a 73-year-old man I'll call Walter. He takes hydroxyzine for anxiety, cyclobenzaprine for back spasms he never quite resolved, meclizine for the dizziness that started last spring, a low-dose beta blocker he has been on for 15 years, and after a recent bout of shingles, gabapentin that he was told to keep taking just in case. 5 different prescribers, 5 different reasons. Each medication by itself was approved for the indication it is being used for. Nobody in any of those 5 exam rooms sat down and added up the cumulative anticholinergic and sedative burden. Nobody ran the math on his behalf. Nobody gave him the score on the anticholinergic cognitive burden scale. This is not Walter. This is someone reading this right now. This is your neighbor, your mother, your spouse, your patient. The medical term for it is anticholinergic polypharmacy, and it may be the single most under-recognized driver of dementia-like symptoms in our elderly population. And the most hopeful piece of this entire conversation is that drug-induced cognitive decline is often reversible. I have seen it personally. When the burden is identified and systematically reduced under proper supervision, the fog lifts, memory returns. Personality reemerges out from underneath the sedation. Your brain is not a passive organ. It is adaptive, resilient, and capable of healing when given the conditions to do so. Here is your action plan. 5 concrete steps you can take starting this week. Step 1, write down every single thing you take: prescriptions, over-the-counter products, sleep aids, herbal supplements, pain relievers, the PM formulation of anything, the allergy pill you started in 2019 and never stopped. Get every bottle out of the cabinet and into a single list. Step 2, look up each one on the anticholinergic cognitive burden scale, often abbreviated as the ACB scale. It is a free, publicly available scoring tool. A simple online search returns it in seconds. Step 3, schedule a medication review with your primary care physician and use that exact phrase. I want to schedule a medication review to assess my anticholinergic and sedative burden. Any good physician will welcome that language. Step 4, ask specifically about deprescribing. That is a real word and a real field in geriatric medicine. It means the intentional, supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk for the body you currently have. Step 5, if your physician is dismissive, get a second opinion. A geriatric pharmacist, that is an actual specialty, can perform a comprehensive review independent of your prescribing doctors. You are not being difficult. You are being the most responsible advocate your own brain has. Before I let you go, I want to hear from you. Which of these 9 medications are you or someone you love on right now? Have you noticed brain fog, word-finding trouble, sleep disruption, or personality change that you never connected to a medication? Have you ever had a clinician dismiss your concern about cognitive side effects? Tell me in the comments. I read them, this community reads them, and sometimes the single most powerful thing is knowing that what is happening to your mind is not inevitable and that you are not alone. If this video helped you today, share it. Send it to a friend who sits in front of a medicine cabinet every morning. Post it in a group you belong to. The person who most needs this information is probably not going to find it on their own. You may be the reason they do. I'm Dr. Sandra Brooks. Thank you for spending this time with me today. Your brain is worth protecting, and now you actually have the tools to do it. Stay sharp, stay informed, and I will see you in the next one.